So this paper is good though, because when I saw this first paper on IHT, I also saw a paper on intermittent androgen deprivation therapy. Can you just talk a little bit about what that means? You don't have to go into specifics and numbers, but what does intermittent androgen deprivation therapy mean? And is it still used anymore? Because you wrote an opinion piece 4 years ago and you were a big fan of it in your opinion piece with Lawrence Klotz. So can you talk about that a little bit before we go on?
Sure. So the whole concept of intermittent therapy, at least from a scientific standpoint, dated back to Nick Bukowski and his group. And at the time, I think Lori Klotz was in his research group. And they were looking at whether or not they could turn testosterone on and off and somehow affect the natural history of the disease. And what they saw in their animal model was that they could. And so they decided to try it in humans. And so the folks in Vancouver did one of the early trials with intermittent therapy. And meanwhile, because our University of Washington and the University of British Columbia were doing some collaborations, I actually went to a meeting up there and heard their whole thing and thought it was really interesting. And at that time, we were starting to see this new group of patients that was defined only by PSA. So remember, PSA didn't really get approved in the US until the mid 80s. So when we were getting into the 90s, we were realizing that there was a bunch of guys out there who had had their surgery, and all of a sudden their PSA was coming up and nobody knew what the hell to do with it. Because you would scan these people, you go, oh my God, what's going on with their cancer? But you wouldn't find anything. All it was PSA in the blood. I mean, we understand that situation a lot better now, but because of the whole intermittent approach, it seemed to make sense in those days to study these men to see, what would happen if you gave them hormone therapy for a certain amount of time. And in our studies, we gave it for 9 months. I mean, there's sort of all over the map that what people have done, but 6 to 9 months of hormone therapy, and then stop it and see how long can they stay off before, you think you should start the hormone therapy again. And that's, of course, very arbitrary if you're just doing it. But I mean, in our study in guys with biochemical relapse, we decided we were getting kind of nervous once the PSA got up to around 1. And so we would restart the hormone therapy then for another 9 months, then go off. And I mean, I still have patients to this day who've been doing that for 10, 11, 12 cycles. So, going on and off and on. Now, unfortunately, I can't say that at least in the fairly large clinical trials that have been done, both in this biochemical relapse group and in men with new metastatic disease, intermittent therapy hasn't really been shown to delay time to castration resistance like it seemed like it did in the animal models. But on the other hand, gosh, I've been giving intermittent therapy for years now, and I have to say that I really do think men, like intermittent therapy. I mean, they like knowing that the ADT is only going to last for a finite period of time, and they know they have something to look forward to when their testosterone level comes up. And, people say, well, it doesn't come up to normal. Well, it doesn't have to come up to normal necessarily for a guy to feel pretty okay. And so I feel like when, we need to think about quality of life when we pick our treatments. And so if we're going to use ADT, we might want to decide, well, could we do it intermittently? I think the paper that Lori and I wrote, we were trying to give clinicians options and some framework about how to think about intermittent ADT, because at that time, the SWOG trial for metastatic patients had been published and everybody was taking it to mean that oh, you should never use intermittent therapy because it didn't, prove anything. Well, yeah, it's true. It didn't prove it was either inferior or non-inferior to, continuous ADT. And so we just wanted to give people an idea of how you could perhaps choose a population of patients with metastatic disease who could probably safely get intermittent therapy and reap the benefits of, having their testosterone come back periodically.
So for men watching this, is this just something that they should talk to their oncologist about to see if they're even a candidate for what we call IHT, that intermittent therapy still has a role for some group of men, that they should just bring up the discussion?
Well, I wouldn't be terribly optimistic.
Yeah.
I mean, that's why we wrote the paper. We were hoping. Now, interestingly, I would say that urologists, I believe, are a lot more keen to use intermittent therapy in their patients than medical oncologists, mainly because they've had the same experience I've had over years and seeing, the quality of life benefits. But I don't honestly think that asking your medical oncologist, it will necessarily get you what you want to hear.
Yeah.
Most of them, honestly, I think most of them are going to say no intermittent therapy for you.
Well, at least we talked about it. The option exists for some people, so if they can at least bring it up. And a lot of people, like I say, go for other opinions today. So